I will. So yeah, we have Melissa Lennon with us today from Altru. I'm excited to hear about their inpatient behavioral health center. So I'll let you take it away, Melissa.
Perfect. Sounds good. Hi, everyone. My name is Melissa Lennon, and I am the Director of Business Development for Altru's. I guess we're not that new anymore, but fairly new inpatient behavioral health center. So, today I'm going to talk about our facility, services, referral process, admission criteria, that sort of thing. And so if you have any questions, please, you can ask throughout. I don't mind at all. I also have pictures throughout my PowerPoint to kind of show what our facility looks like. So here we go. Let's see if I can go to the next slide. So first things first, for those of you who aren't familiar with Altru Hospital in Grand Forks, Altru had the Legacy Hospital, which was the old hospital, and our inpatient behavioral health center or behavioral health unit was located on the fourth floor of the old hospital. We were completely under Altru's umbrella. And then in January of 2025, when Altru's new hospital was finished and all of the patients moved over, that is when our inpatient behavioral health center opened up. And that is, when we first started. So our address is 860 South Columbia Road in Grand Forks. If you look at the picture, that bluish gray building in the background, that is the hospital. And then the yellowish brick building here, this entire building is the behavioral health center. The half that has the two courtyards, that is the inpatient half. And then the other half that's more towards this parking lot and trees is the outpatient half. So just to kind of direct you a little bit more, so this is the hospital, this is the cancer center, this is our facility, and then Columbia Road would be this way. And then the emergency department, you can't see, it would be kind of kitty corner and next to, of course, connected to the hospital. So our facility does have 24 total beds, and we are a secured facility, and I'll get into how those beds are allocated on a later slide. So for our leadership and treatment teams, this changed when we moved from the Legacy Hospital to our new facility. So Katie Pence is our executive director. She is like our CEO. She oversees everything. Crystal is our director of clinical services. Crystal oversees Robbie, our social worker, as well as our activity therapist. So she's kind of in charge of the how we do our programming or group therapy and revamping the schedule and all of that. And then we have for our providers, we have 4. So we have 2 psychiatrists and 2 psychiatric mental health nurse practitioners. And then we also have nurses and behavioral health techs, and they are overseen by our nursing manager. And then at our facility, we also have the luxury of having a teacher through the Grand Forks Public Schools for our adolescent patients. And I'll get into the school part of things later on too. So for our providers, Dr. Chudal is one of our inpatient psychiatrists. And with our psychiatrists and our PMHNPs, they're strictly inpatient. They do not work in outpatient at all, and they are all on site. But Dr. Chudal, his big philosophy for his practice is appreciating what he is not capable of and seeking input from his team, as he believes he's only good as his team. And then Dr. Desai is our other inpatient psychiatrist. She wants to provide the best care possible. And then Maren Mangardich, she is one of our PMHNPs. Her big goal is to use evidence, data, and a patient-first approach to her care. And then Uni Chine is our other PMHNP. She wants to improve the patient's overall well-being and quality of life. So for our providers, we have 2 that are on site each day, and typically it's 1 psychiatrist paired with 1 PMHNP every day. And how they split the patients, typically the psychiatrist will take the adolescent patients and then they split the adult patients between the 2 of them. And so for on-call, we do have our psychiatrists are on call, but we also have outpatient psychiatrists who help on call, which is our like after hours kind of overnight type times. So I know that's often a question is, we can take patients 24/7. We can take patients overnight, whether it's from our own ER or from the region, we are able to do that through our on-call providers.
We do have a hand up. Brenda, do you have a question? You're muted, Brenda. Oh,
Oh,
I'll put her on mute here.
we still, oh, there
Okay.
you go, Brenda.
Sorry. I was gonna type my question. Am I supposed to be able to see the PowerPoint that you have?
Yes.
I don't know where to find it.
Oh, are you on, yeah, I was gonna say, I can see it too, Brenda. So are you on maybe a phone or an iPad?
It's a tablet.
Tablet? Sometimes you have to swipe a few different times to see the, like either the chat or the actual video.
Okay, let me see here.
I'm
See if it's
guessing
in
that's what
the
it is.
background. Oh,
That help?
okay. Yeah, I see it
Kind of?
now.
Nice.
Yeah,
Okay, awesome.
Good. Yeah, I want you to
It's
be able
good.
to see it.
yeah. Let's see here. Okay, first I'm gonna do this. Sorry, I can
Okay, great.
mute myself again.
Okay,
Thank you.
Perfect. Sounds good. Wonderful. Okay. So, who we are and what our milieu is. So, like I said, we are inpatient behavioral health. We serve both adults and adolescents. I'll get into the age groups on a further slide. One thing unique about our facility is we do have 2 distinct units. So, one of the units is adolescents, and then there's a locked door in between, and the other unit is adults. So there is no commingling. They do everything separately. They do their programming separately. They do their meals separately. The only exception to the commingling is if we had an adult that was 18 still in school, we would allow them to go over to the adolescent side to attend the school time. But other than that, they are completely separate. One of our primary modes of treatment is our structured therapeutic programming or our group therapy. And right now, our director of clinical services recently finished kind of revamping all of that. And what our plan is moving forward now is to have every day have their own topic. So then every group that's scheduled for that day will be related to that topic. So for example, if the topic of the day is healthy body, healthy mind, one of the groups might be focused on activities of daily living or ADLs and the importance of proper hygiene and those types of things. One group might be more about like, we could always bring in a dietitian and have it be about, being well nourished, well balanced meals, good nutrition, those types of things. And then there also could be a group that's more related to like activity, like the importance of exercise, whether we bring them outside for that group or we keep them inside and just move our bodies that way. So that's kind of what we're looking at moving forward. We're really looking at bringing in volunteers too to speak on different experiences because we really want to make our groups like more patient specific or specific to the milieu. And so even we've talked to different people that are familiar with different cultures and trying to make something more like specific to a certain patient's culture, or if they're a veteran, make it specific to that, or military service member, those types of things. So Crystal's really working on that, and she's doing a great job with kind of revamping all of that because programming was really that's a really big part of who we are. Before, when we were in the old hospital, we didn't have it at nighttime and we didn't have it on the weekends, and now we do. And there's kind of a certain amount of hours of programming that we want to get in throughout the day. And then for our facility, so we are a short-term facility, meaning that our goal is to bring the patient in, stabilize them, and then help them either discharge to the community with outpatient resources or help them transition to something else, whether it's a step down like a residential PHP IOP, whether it's maybe a drug treatment facility, those types of things. So our current average length of stay is about 5 to 7 days, but that does vary by patient. It's not one of those things where they hit the 7-day mark and it's like, okay, we need to discharge you. It's all based on how they're doing. Of course, some of it can be based on their insurance as well. But yeah, we really want to make sure that we're setting them up for success and, keeping them as long as they need to be with us. So now to discuss the joint venture. A lot of people, even if you're from Grand Forks, are not familiar with this. So as I mentioned at the beginning, we were previously located on the 4th floor of Altru Hospital, under Altru's umbrella only. So now we are actually under 2 different umbrellas. So we are still under Altru's umbrella, but we're also under Universal Health Services, or UHS's umbrella. So UHS is a corporate company with their primary office being located in King of Prussia, Pennsylvania. They are very well known for their behavioral health clinics and hospitals around the country. So when Altru was building their new hospital, the executive leadership team, came together and said, we need to improve access to behavioral health. We need to up our game here. It's a very needed thing across our region. And so that's when they decided to partner with UHS. So we are divided between 2 different entities, and how it's divided is the patients are considered Altru patients. The providers are Altru, and then the billing is all through Altru. So we accept pretty much all insurances that have behavioral health benefits. According to our UR coordinator, we actually haven't come across an insurance that we don't accept. We also accept self-pay as well. If they don't have insurance, that's when our social worker can step in and kind of try to set them up with, if they qualify for Medicaid, those types of things. And so that's all under Altru's umbrella. And then UHS, we really operate the way that they want us to operate. And then our programming is under UHS, as well as the remainder of our staff. So I wear an Altru badge, but technically I'm a contracted worker through Altru and I work for UHS. So that's kind of how the divide is between the 2. And so it very much is 2 entities working together to man our facility, essentially. So here is a picture of an adult room. For those of you, I'm assuming most of you probably never saw our old psychiatric unit. So it was much different than this. There wasn't as much natural light. There wasn't as many pictures on the walls, those types of things. And so in our new facility, we do have much more natural light that comes through the windows. We have the pictures behind the beds. All of our rooms do have 2 beds in them. The reason for that was, number 1, to maximize bed count. Number 2, we really believe in being together and socialization and that as a form of healing. We also want to prevent isolation. However, it does give us the option of temporarily blocking off a bed if we need to. So if we have a patient come in who is maybe more disruptive and doesn't benefit from having a roommate, we are able to temporarily block off one of the beds while they're, with us or while they need it, so that they can be individual or by themselves in that room. And then we do also have bathrooms in each room, and everything in these rooms are safety was number 1 in everyone's mind with the design of this building. And so everything is ligature free in terms of, we don't have the handle to flush the toilet, the sink is different. So everything, the shower is one that tears down. And it is very hard to manipulate too, just for those purposes. And then we do have 2 quiet activity rooms on the adult side. So this one is just with that heavy rocking chair. So this one is one that can be used by an individual patient. They can voluntarily go in there, or we can gently encourage them to go in that room too. It's a way for them to kind of decompress. You know, they can, and the lights are dimmable, so they can kind of be in a darker space. And to calm down or regroup in that room. We also have another quiet activity room. So this can be used by an individual patient or just a smaller group of patients if they want a quieter environment. Again, just a place to decompress. There is a TV in this room, so an individual or a few patients can go in here to watch TV throughout the day. And then here is a picture of our adolescent room. So as you can see, the room is very similar to the adult room. The difference is the background picture is trees instead of clouds. In this picture, I like it too because you can also see the bathroom door. So that door, it reminds me of like really stiff cardboard, and it's actually magnet on both sides. So it's nice because you can move it while still giving the patient privacy, but being able to check on them if needed. It's also like the patient can't use that in any way, shape, or form to harm themselves or others. This room on the right, it looks different because it's ADA compliant. So we have an ADA compliant room on both the adolescent and the adult units. And the difference is the rooms are slightly bigger. We have those end tables with the safes. And then also the bathrooms have different modifications, like it's a walk-in shower, there are grab bars, and then there is a cutout underneath the sink for like a walker or wheelchair to go underneath as well. And then the adolescents also have quiet activity rooms on their side. So their quiet activity room for just an individual patient is very similar. I've seen adolescents use this room as kind of a way to cope. So one time I went on the unit and an adolescent was sitting in the chair with the lights off playing video games. And so that was kind of his way to cope at that time. And then they also have another quiet activity room here too. You'll notice the biggest difference is the size, and that's just because we have less adolescent beds than we do adults. So here is an overview of our adolescent program. So on our adolescent side, we have 6 beds. So that means we have 3 rooms, 2 beds in each room. And we primarily serve ages 13 to 17. People ask about the 11 and 12-year-olds. All of the 11 and 12-year-old referrals we get are case by case. It kind of just depends on what is going on with the patient. It also depends on the age group on the unit at the time. The reason, and then 10 and under we can't accept. The reason for that is our programming is geared for a certain age group. And so there might be someone who comes in it would be more appropriate for them to get children's programming from somewhere else versus the adolescent programming that we offer. And so it's not that we haven't taken 11 and 12-year-olds, it just completely depends on the milieu at that time. And then I just see a chat, so I just want to make sure it's not. That's a good question. So Prairie St. John's in Fargo, I can't remember their bottom, but I want to say they accept as low as like 4 or 6. It's pretty young. And so they're the ones who will take the children right now. And then honestly, other places in North Dakota, I don't know if there's anyone else that takes children. I don't think there is. So Carly, you don't think so either. Okay. Yeah, so I think it's just Prairie. We don't do any partial. We don't have PHP or IOP right now. I have brought the feedback forward to both the outpatient manager and our executive director just because we know there's a need. We know in this region there's such a gap with the in-between aspects of things. We do have the TLC program, the Therapeutic Learning Center, that is an alternative to school. That is that is housed on our outpatient side. However, right now, I think it's just specific to Grand Forks Public Schools right now. So, and possibly like maybe Thompson, but I'm not sure. I know they're looking at East Grand Forks, but the being across the border is kind of a tricky thing too. So good questions. I do bring that feedback forward quite often though, so because we know it's a need. Yeah, I sure, absolutely.
Melissa, read the question so people that are listening back,
Oh, yes.
for the recording, they won't be able to see this.
I forget about that. Thank you,
Okay.
Carly. So the first question was who accepts the children in North Dakota? And my answer was Prairie, St. John's, and Fargo. And then the other question was if we do a partial program for younger kids, and unfortunately, as I mentioned, we don't right now. So yes. And I know those rural areas really struggle with that. The other thing I should mention, is I know this isn't specific to everyone, or applicable to everyone, but there are virtual programs, that are, virtual IOPs that are an option too. So that can always be an option for those, more rural people. And I know the one virtual IOP program, they will even provide the technology for the patients during that time too. So, so that is our age groups. So each patient gets an individualized treatment team and they're overseen by our entire team. So, that team includes, the nurses, the techs, the social worker, the director of clinical services, of course, the providers. And then for adolescents, of course, we want like parents, guardians, family, whoever's, with that child or wherever the child is going to be discharged to, we want them involved too. And then I talked about the daily group-based therapy, and you'll see and later on in slides kind of how this schedule goes. And then we also do activity therapy. And that's a really great component because it's basically taking a leisure activity and making it therapeutic, incorporating CBT, incorporating DBT. And so essentially, with the activity therapy, they do different things like yoga, meditation. The kids really like to make slime. They've made the tie blankets before. They'll do different art, those types of things. And I know they act like they don't want to do it, but they get very attached to it. And if they leave it, they want to come back to get it. And so that's just something they really enjoy doing. I see another question on the chat. It says, are you able to do safety modifications for each? And so I just want to make sure I can clarify and understand your question. Do you mean safety modifications for each patient in the bathrooms and showers? Yes. So, all of the bathrooms and showers, they have, like I said, they're ligature free. And then and I'll talk about this later on, but in terms of the safety part of it too, is that we know that bathrooms and showers and their rooms are kind of a high risk area. And so throughout the day, we really try hard to keep them out of their rooms. We try to keep them in like the common room, or they're going to groups throughout the day. Also, if they're taking a shower or bathroom, or they're using the bathroom, taking a shower, we do safety checks on them. We do 15-minute safety checks. If they are higher risk, we can sometimes, provide those more frequently too. So I hope that answered your question, okay? And then, so activity therapy, the other main form of treatment that we provide for our patients is medication management. Of course, we all know that is a big component of treatment. And so we do a lot with the medication management aspect as well. For discharge planning, we start discharge planning right away. It's such a quick turnaround that we want to make sure that we have them set up the best we can. So we start that right away. We start, we talk to we figure out where is going to be the best place for them to go. And we make sure we have things set up prior to discharge, just so we can set them up for success, because of course we want to make sure they're safe. We want to make sure they don't have to come back to us, those types of things. For school. So we are so blessed in that we have the same teacher and the same para that come every day. And it's for a 2-hour period in the mornings. And it, of course, if they're gone, we have a substitute. But yeah, and then we follow Grand Forks Public Schools schedule. And then we try to get their homework from whatever school they go to, whether it's through Google Classroom, whether it's faxed, emailed, dropped off, those types of things. Because of course, getting behind in school is a stressor. And so we want to make sure that we can do our best to not make that more stressful for the kiddo. And so we do help with school in that way. And we are able to have them take out certain things for school during school time and then put them away and secure them, of course, when they're done. And then family meetings and visitation. So family meetings are required for adolescents prior to discharge. So during those family meetings, we have the social worker, sometimes the director of clinical services, the patient, and then the parents, caregivers, wherever the patient is going to be discharged to, because that's when we set up a plan for home. That's when we do our safety planning. We make sure they don't have access to firearms or weapons. We make sure their medications are going to be locked away so there's not, a risk for overdose and those types of things. We make sure they know who to call in times of crisis, where to go. And so all of that happens during that family meeting so that everybody is on the same page and everybody feels comfortable with that discharge. For adolescents, typically what happens is the family meeting is scheduled, and if all goes well, the patient can be discharged right after. So say we have a patient who lives in Bismarck, so of course that's a almost 4-hour drive. Then the parents would come, they would do the family meeting, and then they would get to take their kiddo home right afterwards so that it's not like they don't have to drive up 2 separate times. And then also with family meetings, we do try to incorporate the teacher maybe afterwards, just so we can all be on the same page with reentry back into school too. And then I'll show you a picture of the courtyard here too. So the adolescent activity room. So this is kind of the common room that I talked about. This is where they spend a majority of their time throughout the day. They do groups in this room. They have snack in this room. This is also the room that we store a lot of different coping activities. So we store things like, coloring, word searches, crosswords, games, books, those types of things, so that they can independently work on coping strategies. This is also where we have the TV and the rolling cart. And we don't store the rolling cart in there all the time. It just happened to be in there when I took the picture, but they are able to watch TV, watch movie, play the Wii, or play video games only at certain times of the day. It's not like it's on all the time, it's in use all the time. It's only at certain times of the day that they can do those activities. And then this room has a dual use essentially. So it's number one, it's used for school. So typically the tables and chairs are set out, and then each kiddo can kind of have a table to themselves while they're working on school. And this room is also used for activity therapy because it is a larger room. So if they need more space for moving their body, for yoga, something like that, then we are able to use this room for those purposes. And this is the adolescent courtyard. So the adolescent courtyard is completely walled in. So we cannot see this from the outside, just the aerial view. It does have artificial turf. We do go out prior to going outside to make sure there's nothing that could be used to harm themselves or others. It's used for 2 different things. We can use it for activity therapy, but we can also use it just to give the patient some fresh air, time outside, those types of things. So it really is a nice space for them. And now for the adult program. So on our adult side, we have 18 beds. We serve ages 18 and up. And I get asked a lot about kind of the maximum age that we serve. We really don't have a cap on that. We actually recently had an 88-year-old on our unit. That is the oldest I've seen in this position so far. And so it just depends on the appropriateness and if they meet admission criteria. But again, the adults have this, individualized treatment plans just like the adolescents. They have group therapy as well. Of course, their group therapy is going to be geared differently. They might have a group related to relapse prevention where the adolescents don't. And their activity therapy might be a little bit different. I have been told that the adults like the slime though, just as much as the kids do. So that is an activity that they will do during activity therapy. But yes, it's very similar. It's just their schedules are a little bit different. Again, we do med management for adults, and I know this is the same with kiddos too, but sometimes adults just stop taking their meds. And it's just a matter of getting them on their meds again, getting them on a schedule, knowing when they're supposed to take them, those types of things. And then again, discharge planning starts right away. And the big difference between the adult program and the adolescent, besides the age and the number of beds, is that family meetings are only as needed or as requested. They're not required prior to discharge. Just because, of course, adults are more independent than children or adolescents. And so, we can do safety planning individually with that adult before they are discharged. And then we have a courtyard for them as well. So this is the adult activity room. So this is where they spend a majority of their time throughout the day, do groups, and this is where we store or have those coping activities that they can work on independently throughout the day. And this is also where they do snack and all of that. In this picture, I like this one because you can see the nurse's station. So as you'll notice, you can see the white, that's a shelf, and then there's 2 doors. So one huge difference between the old facility and the old hospital and this new one is our nurse's station is open. So in the old hospital, everything was enclosed and the only, we had access to the patients. We would usually leave like the top half of the door opened. Now it's completely open so we can be more engaged with the patients. They're able to come up to the nurse's station to ask questions. We can monitor them if they're walking in the hallways, in the group room, those types of things. So that is a big difference between the old facility and the new one. And then this is one of the group rooms for the adults. So this one has a whiteboard. So they could use this if they needed the whiteboard for group therapy. This is also a nice room because we use this for our interdisciplinary team meetings in the morning. We also use this for like our staffing during shift changes as well. And then one thing I didn't mention, but every one of these chairs that you see in our facility is one of those really heavy kinds that you cannot lift, you can only slide them. And everything on the wall is very secured to the wall using like safes, safe screws and such. They also almost have like a putty type thing, so you can't get your fingers around it to take it off the wall, anything like that. All of the TVs are enclosed in a case. You'll kind of see that in upcoming pictures too. And this is the adult courtyard. So if you live in Grand Forks and you've been near the hospital, you've probably seen this. It is only walled in on 2 sides and gated on the other 2. And it eventually will be completely walled in. But yes, this is the area they can do activity therapy. We can take them outside. They can walk around. They can play with a soccer ball, volleyball, those types of things. So for the daily routine, so on the next slide, you will see the daily schedule of groups that the patients have to work on those coping skills, work on processing why they're at our facility, what they need to do to help get better and heal and all of that. We also schedule in phone and visiting times throughout the day. And that is purposefully just to make sure we're not interrupting groups. We wouldn't want people randomly doing phone calls throughout the day, having visitors come. So there's only specific times allotted for those things. Our interdisciplinary team meetings, they meet every morning. This is where they go through the patients, talk about each patient, how they're doing, their treatment needs, their discharge plans. And this is a lot of times where a lot of coordinating of care happens, where the social worker talks about who she's talked to, who she needs to talk to, those types of things. And like I said, our unit is staffed all the time with nurses and techs. And we do 15-minute safety checks. So for those checks, that's when we walk around, we find where each patient is and what they're doing. If they are sleeping, we need to see 3 breaths. And if they're in the shower, we need to see their hands and face in order to consider it a completed safety check. And for the schedule, you'll see it's nicely color coded, so it's easier to see what we have going on throughout the day. So everything in green, that is a group. And so some groups are shorter than others. And they're all led by different people. Some are led by our director of clinical services. And her degree is in counseling. Some are led by our social worker. Some are led by our activity therapist. Some by our behavioral health techs. So they're all just kind of different in that way. Everything in orange, that's mealtime. And then red for the adolescents is school. And anything in yellow is stretching, meds, free times, breaks, snacks. And then purple, that's our visitor time. So it's a 45-minute slot because we do allow 15 minutes to get on and off the unit. So that's when visitors come. We typically want to know by noon, the day of, that a visitor is coming. When visitors come, we have to scan their IDs, and then they have to leave everything in a locker. They can't bring cell phones, anything like that back for safety purposes. And then it does only show one phone time in here, but there is additional phone time scheduled. I think we have 1 to 3, 3 to 4, and then in the evening as well. Just because we want to make sure every patient has adequate time to use the phone, even if they're having a visitor. And then the other thing in here, of course, is hygiene in gray. And then the adolescents have meal tickets. So we have menus very similar to the acute hospital. There's just a few differences. So they pick out their meals the day before on what they want. They pick an entree, they pick sides, they can pick a dessert, they can pick a drink, those types of things. And so sometimes we assist with that too, just to make sure they are getting like protein, veggie, fruit, all of the food groups. This is our dining room. So this is where they come for meals. Like I said, they eat separately. Snacks are brought to them on the unit. And of course, one of our main priorities in our unit is safety. And we have various components that help keep our unit safe. The first one is our unit is very secured. So everything is either badge or key access. And then on any exit door off the unit, whether it's exiting outside, exiting into a different hallway, we also have a keypad, and everyone's badge is associated with a different code so that I scan my badge, type in my code, and then I'm let out. So even if a patient were to get a badge, they would be stopped at that point because they would not know the specific code. So it's kind of an extra safety feature that we have. We also, for dining utensils, we use plastic forks only and styrofoam everything else. We do restrict belongings. So they come to us, we go through all of their stuff. We store smaller things in smaller containers, larger thing in larger containers. So they don't get, the only time they get their phone is maybe right at the beginning if they want to get phone numbers off of it. Otherwise, it's put away and they use our phones. And then 2 things that we were trained on by UHS to handle patients who become agitated or aggressive. So the first one is the hands-off approach. It's trauma-informed care verbal de-escalation. So, trauma-informed care is using, being aware of what the patient is going through, what they have been through. It's using a certain tone of voice. It's using certain verbiage. It's trying not to say no, but redirecting to something else instead. It's also using space, trying to de-escalate them verbally. And then we do have a hands-on approach called Handle with Care. And that's learning how to put patients in physical holds with at least 2 people or more. Rather than using mechanical restraints. We no longer use mechanical restraints. We just use these 2 forms of handling with hands-off and hands-on approach. So now I'm concerned about someone, now what? So here is the referral process. First and foremost, all patients must meet admission criteria, and I will go into that in more detail. So any patients who are local to Grand Forks or live nearby, of course, sometimes we have patients drive from Hillsborough here or Larimore here, those types of things. they can go directly to Altru's emergency room to be assessed. If, we have a regional patient, so right now, all of our patients have to go through an ER or hospital because we need medical clearance. So if you're regional, you would send them to the local ER, and then that ER would call our intake number at 701-780-3440. They would press option 2, and that would bring them to intake. So, and if you're not an ER or hospital, you can use that number. You can call to ask if we have open beds. You can call to let us know, hey, I sent this patient here, the referral will be coming, those types of things. Once, we do a quick screening over the phone, then we say you can fax information to us for our intake manager or charge nurse and psychiatrist to review. Once we decide whether or not we are going to admit or not, we will call the referral source back to let you know. Our goal is for this process to be under 2 hours in terms of, acceptance or declination. So this is the current referral process. However, this will be changing, and hopefully it's this spring or summer of 2026. We are eventually going to have a fully staffed, fully operational intake department. So that will allow for 3 specific things. So one thing is we'll still take referrals from ERs and hospitals. Number 2, we will have a walk-in component. So patients who are local will be able to walk right into our facility and not have to go to the ER first. Number 3, we'll be able to take referrals from pretty much anywhere. Social service agencies, schools, outpatient clinics, primary care clinics, anywhere, those types of things. So once that's up and running, it's going to be amazing for our community because I definitely think it will improve access, of course, to behavioral health. And I think more people will be willing to come in for services if they don't have to go to the ER first, because we know that can be a deterrent for some patients. So, criteria A for our admission criteria. So they basically have to have a plan and intent to seriously harm themselves or others because of a psychiatric illness. So they have to have some sort of suicidal or homicidal ideation, a recent and serious suicide attempt, or a deadly threat to harm others, or if they've had violent, impulsive, unpredictable behavior in which they would need 24-hour monitoring. And with the violent impulsive behavior, we do have to be careful on how high acuity we can get. We don't have a specific high acuity area anymore. So in order to keep our staff and other patients safe, and just for it to be therapeutic and healing for everyone, we do have to be a little more careful about how high acuity we can take. Criteria B, if they have a psych illness that can't be treated at a lower level of care, that would be another reason they would come to us. So maybe this is causing them to be unable to perform their activities of daily living. They have bizarre thinking, they're slowed or agitated in their movements, requiring 24-hour care. And of course, we see lots of different psych illnesses. We see depression, anxiety, bipolar, psychosis, hallucinations, PTSD, suicidal ideation, homicidal ideation. The list goes on in what we can see. And then criteria C is if they have some sort of secondary condition that can't be provided at a less restrictive level. So maybe they have a general medical condition and they require acute psychiatric intervention. Or if they continue to go to outpatient week after week or day after day and meds aren't being adjusted correctly, maybe they just need to come to our facility to be monitored, to go through some programming, get meds adjusted in a safe, secure setting. So here's a picture of our exam room. So this is where we take patients on admission if we need to do labs, any sort of exam. And then we also have admission criteria for observation. This is when we believe the patient would clear in 24 hours or less. So for example, maybe a patient is intoxicated, they have suicidal ideation, they might clear in 24 hours or less. And then this is one of our consult or assessment rooms. So this is where a family meeting would happen, or just any sort of confidential meeting that needs to happen. So for our exclusion criteria, so if their blood alcohol level is greater than 0.1, or they have a drug level changing their consciousness, it's not that we can't take them at all. We can't take them at that time. So they would need to detox in an ER or in the hospital before they would come to us. Just because we are not a detox center in any way, shape, or form. So that would be what needs to happen. If they have any medical conditions that require acute care, of course, we're right next to the hospital, but we don't have the means for that that the acute hospital does. If the patient has severe dementia, we can't take them because we need them to be able to participate in programming. Same with the airborne precautions, we need them to be able to participate in programming. If they're on hospice, we can't take them for that reason. And then for the total assist with transfers or ADLs, we can take patients with assistive devices like walkers, canes, wheelchairs, but they pretty much have to be independent with those. We just don't have the means staffing wise to take a staff off the floor and provide that one-on-one assistance all the time. And our facility is not equipped with like hospital beds that can be raised up, different sort of like trapeze bars, bed alarms, or even a call light, just for safety purposes. And any patients with specialized cancer care, including chemo or radiation, any IVs, ports, HICS, or HEPs. For wound care, we can take superficial wounds and those types of things, but again, we don't have air beds and all of that equipment needed for more extensive wound care. If patients are on dialysis in renal failure or end-stage renal disease, and then when I say severe eating disorders, I mean eating disorders of patients that aren't in recovery, just because we don't have that specialized care that those patients need. And then if a patient is seeking admission in lieu of jail time or currently incarcerated, we can't take them for that reason. So these are kind of hard stops for the most part. But a lot of times I still tell people to send the referral anyways, because it's everything, just for our team to review. And this is the documentation that we do need from the ER or hospital. So, we can't do any direct admissions right now just because we do need that medical clearance. I'm not sure if anyone on this meeting is from Minnesota, but we do take patients with Minnesota holds and committals. Of course, we just need the proper paperwork for that. And then discharge planning. I did talk about this a little bit. It involves our whole team. Of course, everything we do as a team here. And so we want to make sure everyone's on board. We're all on the same page. We help set up outpatient appointments and services. So if a patient has been seeing a certain psychiatrist, therapist, counselor, of course, we try to set them up with them. If a patient hasn't been seeing anyone, we try to set them up with their primary care provider for the referral to see somebody to continue. Of course, we help with med management. We make sure they're going to be able to pick up their meds. They know the schedule of when to take them. And then I talked about school. We do work with schools to help with that re-entry back in. And then plans for the future. So I talked about the opening of the intake department to allow direct admissions and not having to go through the ER. The other exciting plan that we have is our expansion. So if any of you have been to Grand Forks and been around the hospital lately, there's a lot of construction going on. They're kind of redoing some roads, adding some parking lots. And then after that, they're going to start our expansion. So our expansion is slated to be completed in November of 2026. If any of you are familiar with the recent legislative session, all of that funding that did get approved, and that was some of that funding was for our expansion. So we're really excited. What it will do is we will add 24 beds. So we will have a total of 48 beds. And kind of the plan for that is we want to make the current 6-bed adolescent unit a high acuity unit. We want to make the current adult unit more of like a transitional, and then take the new 24 bed area and make it 12 and 12. So we'd go from 6 adolescent beds to 12 adolescent beds, and then have another 12 adult beds. So that's part of the expansion. We're also gonna add a 3/4 indoor gymnasium. So I'm really excited to have a bigger indoor space for the patients. They're also going to remodel the intake area or front like lobby area right now because it's not very conducive to walk-ins at the moment. And then the fourth thing is they're gonna build an overground or above ground tunnel between the ER and the and our facility to make it easier for transport to and from. And so that's what's going to be happening over the next year. And so this is what they have as a picture of the rendering of what they think it will all look like. So when I showed you guys the picture of the partially gated adult courtyard, they're planning to build around that and into the parking lot more. And then they're planning on building more north, so away from the hospital towards like Columbia Overpass, that direction. And so this is just a reminder of the referral process. For regionals, it's the 3440 number. For local patients, we want them to go directly to Altru's ER. And then that is the end of my presentation. Does anyone have questions?
It's cool to see all the pictures and the inside. Looks great.
Yes, it's very nice.
Yeah. Any questions? You can unmute yourself. You should have that capability, or you can raise your hand and I can help with that, or you can type in the chat.
Sorry, I came in a little late. I was curious as to who does this apply to?
So we are inpatient behavioral health. So we serve adults and adolescents. Adolescents is ages 13 to 17, 11 and 12-year-olds are case by case, and then adults are 18 and up. So this applies to patients who have a psychiatric illness and are experiencing, a suicidal crisis, maybe a homicidal ideation. They might not be able to be treated in an outpatient setting. They might be having trouble with adjusting medications appropriately. So, we take patients with anxiety, depression, psychosis, hallucinations, bipolar, PTSD, all of those different psych illnesses, suicidal ideation, homicidal ideation, recent suicide attempts, those types of things.
So, because my mom just got sober and she's having, because she was having psychosis at the end of her drug use.
Okay.
And she can hear things, and we're trying to get her set in diagnoses. We haven't yet. But she can't remember things. It's kind of almost too a little scary because in my household I have a bunch of kids. So then she constantly is forgetting everything. So would it be someplace that could help with that? Like
Possibly, yes. And I mean, if she's seeing and hearing things and having those hallucinations and maybe it's a medication thing, that would, and in order to adjust her medications in a safe, structured, secured environment, I think that would be helpful.
So all I have to do is see if I can get a referral from her doctor here.
So for us, all of our referrals have to come through the ER. So you would have to bring her to the ER. If you wanted her to be seen like outpatient, where you just bring her to the clinic and she's seen that way, then you need a referral from her provider. And that could be another option too.
Awesome. Thank you for your help.
Yeah, you're so welcome. Thanks for your question.
I had a question. When you had the page up for the schedule between adolescents and adults, I was a little curious why the adolescent doesn't have journaling on their side. Because with behavioral health, I know that a lot of adolescent teens, especially, they, whether it's brain injury or not, they find journaling very helpful for them. So I was quite surprised that that was not in their schedule.
So what I think it is, because I think the adults, the journaling was separate, right? Like it was its own thing.
Well, it was twice. There was
Yes.
journaling
So
twice in their schedule.
I think what it is that journaling, we do journaling with the adolescents, but it's part of a group because the adults can be more independent with it, but the adolescents, we might need to kind of guide with it a little bit because I know they do journaling because they get little books. And I remember one time I was upstairs and one of the adolescents wanted me to write some positive like words of affirmation in it with my name. And so I know they do it. I just think it's more like the adults are more independent and can be unsupervised doing it, where the adolescents need to be supervised, if that makes sense.
Okay, I just didn't see it actually worded, so
Yes, and I
just
don't think it's
wanted to.
worded in there, but I think I know it's part of one of their group therapies.
Okay, thank you.
Yes, good question.
I guess I have a question.
Yes, Brenda.
Do you accept people like anoxic brain injuries? Someone you know that's always gonna have this like, condition.
I really think it depends on what they have going on. And
Okay.
and cognitively, if they're able, to participate in, the programming aspects of things. I think it really just depends on I don't think that we could admit them purely for the brain injury aspect diagnosis, but if they had other things going along with it, I think that we could look into it.
Okay.
Yes,
you.
good question.
Any other questions for Melissa?
I think everybody pretty much answered my question. I was wondering about, because we have a lot of individuals that are in drug-induced psychosis. Even when they're not using drugs, they're stuck. They're stuck in the psychosis. And so it's really come to a real hard situation because we can't get them help when they're there, to get them monitored and get them on medication and see what some kind of stabilization. Is that something that you guys can do if they're not actively using and they're just stuck in that psychosis?
Yeah, so that's
What if they're not suicidal and they just can't?
the psychosis piece we do take, yes.
Okay.
It depends on how high acuity they are, a little bit, but we do take patients with psychosis. And the other thing too, we don't do specific substance abuse, however, if it's paired with a mental health issue, then we do. You know what I mean? A lot of times we'll treat the mental health piece, and then we will send them to like a drug treatment center or facility. So yes, we would, and we do take patients with just psychosis. So good question. And then I see one in the chat too, Carly. So the question is, why are adults not given an option for meals? So I didn't clarify this well. They are given an option. It's just that, again, they can do it more unsupervised and independently, where the adolescents need that supervision. So kind of along the same lines as the journaling.
I know you covered this, but I just have to remember. Now, does the person have to be insured in order to get into your facility, like on Medicaid or Medicare?
No. So we take all insurances, and we do also take self-pay. And I mean, we do see a lot of homeless patients as well who are oftentimes uninsured. So yeah, we really, in terms of that, like that's usually not a barrier.
Okay, I just wanted to make sure on that.
Yes.
Okay. Okay, thanks.
And I should mention, we take TRICARE, we take VA, Medicaid, Medicare, Whether, you know, Blue Cross Blue Shield, Cigna, Aetna, all of them.
Well, I'm excited to be able to see you guys grow and develop in your programming. I'm over at Northeast, and it's just exciting to see more services available in the community. So
Yes.
thank you.
Yes, thank you for saying that. I know, and we, our partnership with Northeast is very important to us, and I've heard feedback that it's improved tremendously since we moved to this new facility, so I'm happy to hear that.
Yes, it's all about the client, right?
Yes, that's the thing. It's all about the patient. Yes. We want to serve and help the patient. Absolutely.
Exactly.
Yes.
So thank you for everything you do.
Yes, thank you for what you do.
Yeah.
Anyone else? Any last questions for Melissa? I'll echo what Jane said. I agree. This is great for Grand Forks and just this whole northeastern region of North Dakota. All right. Well, I don't see any questions coming in. So thank you, Melissa, for your time. And
Yeah, thanks for having me, everyone.
this is recorded and archived, and so it'll be put here, and the link in the chat there is that ndbin.org/event/webinar, and that's where you can find your CEU request as well. So look forward to talking to you guys again in a couple weeks. Thanks, Melissa. We appreciate
Thank you. Bye, everyone. Have a great day.
you too.